soon. It will show the status of the chapters for the current review cycle. And we will also provide the links, and all the supporting documents that are related to the chapter will be included there. So that is an example of how it will look, but it should be up very soon. And yeah, thank you, Chair. That was my story. I will now hand over to Prof. Robertson. Thanks, everyone.
Thank you, Marapeng. I shall just share my screen, and good afternoon, everybody. I shall just be going through the primary care and adult hospital chapters very, very quickly. The non-pharmacological updates and emphasis that we've placed on prescriber restrictions, and then to go into more detail on aggressive and disruptive behavior and changes to the guideline there. And then I shall hand over to Dr. Nyako, who will talk about opioid agonist treatment. So to start with, as Marapeng has highlighted, the guidelines and the evidence, accompanying evidence, which has supported the decisions, are available on the Knowledge Hub. And to emphasize that this talk is not fully comprehensive, it's only an update and should be used alongside the standard treatment guidelines. So non-pharmacological amendments, we did make quite a few, and the two that I'd like to really emphasize is psychoeducation and risk assessment. So we've added fairly detailed paragraphs in the introductory matter for both the primary healthcare and the adult hospital level mental health chapters, describing what psychoeducation is and what a risk assessment is. And essentially, with psychoeducation, it's a little bit more than teaching a person about the illness or the disorder. It also includes tailoring the education to their understanding, their cultural beliefs, and with the goal of improving adherence and preventing relapse, and to improve their care outcomes. So psychoeducation can be much more in-depth and often needs the family as well. And it requires some inquiry as well as education. So you need to understand how they're thinking and how they're feeling about what they're being told, about having the illness, and about the treatment that's being offered to them. A risk assessment is a clinical judgment. It doesn't have to be absolutely correct. You don't have to be certain that the person's at high risk, but what you're doing is you're making a judgment from the history that you've got or the observations that you've made as to the risk of that person to themselves, to others, and for a variety of things. So the risk of being exploited, the risk of high-risk sexual behavior, the chances of or risk of non-adherence, the risk of harming others. And I think both of these, with the risk assessment, we've provided a link to a tool which is not South African, it's international, but it does give a good idea of what is involved in a risk assessment. And the actions that you would take after assessing somebody at high risk, mostly it would be to include the social worker, discuss the person with the social worker, refer them to either the clinic social worker, to a social welfare officer. And you may have to explain to the patient that you will be breaching confidentiality because you are worried about their safety. So we've tried to give some guidance. And then we've added non-pharmacological measures in the management, some red flags for each condition, the importance of monitoring after treatment initiation, and that all patients require a multidisciplinary approach. So we've included social workers, occupational therapists, and registered counsellors in particular, considering the NHI grant that is available and that mental health professionals are being contracted in most districts or in the country. So we've emphasized that the Schedule 5 medication to all psychotropic medication is Schedule 5, and this is not new, it's old, it's just that there's been some awareness around the legislation and that we didn't have it specified. It's all doctor prescribed, so it cannot be initiated or repeated by primary healthcare nurses. And then we've made olanzapine doctor initiated rather than specialist initiated to facilitate access. And to go on to aggressive disruptive behavior, so just to remember, and again, I really would encourage you to go through the guidelines, whether it's for PHC or the adult hospital. There is quite a lot of detail on preparation. So each facility should have a drill and some protocol as to what they would do if there's an aggressive and disruptive person in the clinic. And people who are well known to that facility, all the staff should be in the know about past behavior, put it that way, and that to whether to expect it and how to de-escalate. So remember that agitation may escalate to overt aggression. Agitation may present as restlessness, pacing, or loud or demanding speech. Aggressive behavior includes verbally abusive language, specific verbal threats, then intimidating physical behavior, and actual physical violence to self, others, or the property. And there is and has been shown a pattern of escalation of this. So the idea is to address the problem at the stage of agitation. Agitation and aggression should be considered an emergency, and violence should be prevented or minimized wherever possible through de-escalation of the person. In children and adolescents, the aggression may occur suddenly without warning signs, and particularly in children with neurodevelopmental conditions, such as intellectual disability and autistic spectrum disorder. So all children and adolescents must be treated respectfully and calmly. Well, all our patients should be, but I think we can become rather domineering over the children and adolescents, and we may respond with an equal amount of aggression, which could be very dangerous, particularly with people with intellectual disability. Be aware that the busy, noisy clinic environment may be provocative and precipitate aggression. So have a protocol which has a quiet room and a calming space. The idea really is that you should be looking for the causes or potential causes of aggressive behavior the minute you notice that somebody is agitated. So as you walk into the clinic and you see people in the waiting area or into the casualty or the ward, you pick up agitation or aggression, start thinking what are the possible causes. And they may be physical in terms of illness, delirium, epilepsy, intracerebral lesions, traumatic brain injury, psychiatric causes, particularly psychosis or mania. And then the neurodevelopmental disorders, again, are not a cause in themselves, but the problem is people with neurodevelopmental disorders may find it difficult to express their frustration and pain as well, or if they're feeling abused or have been abused. Substance use is extremely common in our society and is a very common cause. So just remember, though, that substance use causing agitation or aggression is also causing other physiological effects in that person. And so be alert to physiological factors. This is meant to be psychological factors in the last one. So in psychological factors, we're thinking really of personality traits, people who have very high levels of impulsivity, or antagonistic personalities. They're very sensitive to rejection or insult. So you can imagine if you turn around as a staff member, you're short and sharp with them, you dismiss them, or they feel dismissed, you might exacerbate the aggression and the potential violence. All of the causes need a slightly different management approach, which we will tackle just now, go through. We've made a few comments on the non-pharmacological interventions for the management of aggressive disruptive behavior. Your primary intervention is non-pharmacological, and there is quite a lot of do's and don'ts that we've listed in the SDGs. We've just added the importance of listening, and we mean active listening with understanding to the person and counseling their family. And that's counseling the family perhaps after you have sedated and restrained the person, if they've had to be, and explaining to them what the approach is and what is happening. We've added a note on the management of pregnant women with agitation or aggression, and it's really to be gentle and to be aware. Don't place them in a prone or a supine position. They should be gently lowered into a semi-seated position, and restraint must be applied very sparingly and when absolutely necessary. So the idea is to approach people as calming, reassuring, but with confidence, and letting them know very clearly and helping them to contain their behavior. So letting them know it's not acceptable, but assisting them with the tone of voice and the reassurance that to contain their behavior. We provided the link on the policy guidelines on seclusion and restraint, and just added a note on the fact that the Mental Health Care Act Form 48 should be completed if restraint is used for a person admitted under the Mental Health Care Act. So if you're using restraint for somebody who's delirious or has a medical condition causing the aggression, the Mental Health Care Act does not apply. It applies to people where the aggression is directly related to the severe mental illness. And that all injuries or deaths associated with the management of the, as well as to your health facility quality assurance. And mechanical restraint should be prescribed by a medical doctor. So medicine amendment, we've made quite a few of them, and this is because the haloperidol intramuscular formulation is not routinely available in South Africa at the moment. In fact, has not been supplied for quite a few years. There may now be a supplier in South Africa, so it may come on tender again, but we felt that we needed to make sure we've got something of reliable supply that is effective in what we call rapid tranquilization. So we've deleted the intramuscular benzodiazepines together with the haloperidol and promethazine from the primary care guidelines, and we've replaced that combination with olanzapine intramuscular and the option of an orodispersible tablet. And then in children, we've deleted both the haloperidol and promethazine because of
Recording in progress.
and replaced them with haloperidol and promethazine with olanzapine IM and the orodispersible tablet. So you can offer the orodispersible tablet before giving the intramuscular. And then under specialist supervision or consultation, once in a ward, we have obtained the use of zuclopenthixyl acetate, which gives 72 hours tranquilization. So just to make a few notes around olanzapine, because this is new and we have not had experience with it in the public health sector, but it's available in South Africa as intramuscular injection and as an orodispersible tablet. The orodispersible tablet dissolves immediately and is absorbed through the buccal mucosa or under the tongue, so that you get a much more rapid onset of action than an oral tablet of olanzapine. And the dose in adults and in pregnant women is 5 to 10 milligrams. In elderly or frail people, it's 2.5 to 5 milligrams. The adverse effects, the weight gain is not such a concern, obviously, in emergency use, but severe sedation maybe, and hypotension. And the reason we have removed the intramuscular benzodiazepines is because it is recommended to not give it simultaneously or within 2 hours of an intramuscular benzodiazepine because of the excessive sedation. Olanzapine may potentiate the effect of the benzodiazepine so that you get a greater effect from that. And this is particularly a problem in people who use alcohol. And then olanzapine, we've got oral tablets already for the treatment of schizophrenia and bipolar disorder, but it may also be used, as we said, intramuscularly here. So we conducted an evidence review just to ensure that, to examine the safety and efficacy of olanzapine in treating acute aggression and agitation. We found very poor quality international guidelines. So we had a look at the literature. Of the 6 systematic reviews that we identified, we included 2 in the evidence synthesis as being of sufficient quality. And we examined 13 randomized controlled trials. And the key findings were that after half an hour, 30 minutes, there was no difference between olanzapine IM versus a double the equivalent dose of olanzapine in haloperidol and promethazine combination. And this was one of the TREC studies, and it's considered high certainty evidence. At 24 hours, and compared to lorazepam, so a benzodiazepine, we found the risk of no improvement was less with olanzapine than lorazepam. So 24-hour effect seems to be stronger with olanzapine. And this was very low certainty evidence. And to note that at the first hour, there's no difference between olanzapine and lorazepam. So the positive side is that the olanzapine injection might last longer in its effect. And similarly, against lorazepam, at 24 hours, we found a greater reduction of agitated behavior with olanzapine. And compared again to haloperidol plus promethazine, olanzapine resulted in a greater reduction at 2 hours after the injections in aggression and agitation. So at worst, the olanzapine injection is equivalent to haloperidol and promethazine and to lorazepam in the short term, and it may actually be have better results after 2 hours compared to haloperidol and promethazine, and after 24 hours compared to lorazepam. So this is the algorithm or flow diagram for the adult hospital level, so the district hospitals. just as a guideline for when somebody is brought into the casualty with aggressive or disruptive behavior. So they may be brought in by the police service or by a family or neighbor or other. Generally, if they're brought in by the SA police, well, always if they're brought in by the police service, the police should fill in a Form 22, which explains why they picked him up or why they have brought him into hospital, and so why, if they've had to restrain him or what they've had to do. So this is a Form 22 actually justifies the police action in restraining that person and bringing them to hospital because of the aggressive disruptive behavior. The casualty officer or the nurse in casualty would complete a Form 1. The Form 1 simply allows you 24 hours of involuntary care because you consider the person a danger to themselves or others, and the behavior is uncontained, and it gives you time to work out your diagnosis. So it again justifies any acute sedation within 24 hours in the person's best interests, although it might be against their will. The Form 1 does not register the person as a mental health care under the Mental Health Care Act. It's not an admission into the ward under the Mental Health Care Act. It's an emergency measure to justify acute sedation if there's a risk of danger to themselves or others. If they're brought in by a family or neighbor or other, the accompanying person should be asked to wait. Don't just allow them to go. Don't just shunt them out. They should be asked to wait, and somebody should be allocated to them from the casualty to take a history, find out what's going on, and to complete a Mental Health Care Act Form 4, which is an application for an assisted or involuntary admission. And in that Form 4, the person would explain why they believe the person needs admission, even if it's against their will. At the same time, that person should then counsel the family or neighbor as to what is happening in the casualty. From the minute the patient arrives, examine them as they're walking, as they're talking. Are they coherent? Are they logical? Do they appear medically stable? Do they seem to have a clouded consciousness? Look for signs of delirium or head injury, even if this is somebody who is known to have a severe mental illness. They are more likely to get head injuries than the general population, and they are less likely to seek help appropriately if they've got a severe medical illness. So they may only present with delirium. De-escalate, contain. If they're contained and cooperative and they respond, you manage the main complaint. And all that we changed here is if they then remain cooperative, they take the appropriate treatment, the admission is unnecessary. There's no forms to fill in. There's no Form 3 here. You simply discharge them from the casualty with a referral letter and all the investigation results that you might have done to outpatient care and or substance use rehab. Substance is so common in these patients, and we should be referring them to social development rehab centers. If they're not contained and cooperative and they don't remain it, you then have to fill in the remaining Mental Health Care Act form. So you've got your Form 4 from the family, 2 Form 5s, the Form 7, and you admit as either involuntary or assisted user. In that 72 hours, what you are doing is you are initiating the involuntary psychiatric observation period. The 72-hour admission is not a medical workup admission, although a medical workup very often occurs in that admission. So the medical workup would happen even if the person is not refusing treatment, if they're coming in voluntarily, but they have been extremely aggressive. The 72 hours is specific to psychiatric management. And this can be done by non-specialists in non-specialist hospitals. It's extremely important in this observation period to be monitoring all the time their mental state as well as their physical health and their vitals, to note whether you're detoxing from any substances and how they have responded to that detoxification, and to institute the initial treatment for both the psychiatric and or medical conditions. At the end of the 72 hours, there's a decision as to whether they need further involuntary or assisted care, whether they need transfer to a specialist psychiatric hospital, to a psychiatric ward in a general hospital, or whether they are now stable. And this may happen in somebody who really is coming in with acute intoxication or acute withdrawal, and the substance use management actually is what's needed. And then they're discharged with a Form 3 if they have been observed for 72 hours. To note also that the obligation is to refer up if it's beyond the scope of practice of the hospital and the practitioners in that hospital. If there aren't any possibilities of referring up, then to consult with a higher level hospital, especially if you've got somebody who presents an ongoing risk to themselves or others. So that's my presentation. Thank you very much. I'm going to hand back to you, Peng.
Dr. Khalabi, you can go ahead. Thank you.
Okay, thank you very much. Can you hear me?
Yes, we can.
All right, no, thank you very much. I'm going to present an update on opioid agonist therapy implementation research project. Next slide, please. Overview of the presentation. I'm going to give you the purpose and go through the background of why, so that we understand why pilot testing OST in the public sector. And then I'm going to go through you about the objectives of the pilot project, and then give you project update of where we are and where are we leading to, and from there end up with a conclusion. Next slide, please. The purpose is to update on progress made regarding opioid substitution therapy, and is currently known as opioid agonist therapy. It's implementation research to stakeholders. Next slide, please. As a background, the non-medical use of illicit opioids, especially heroin-consisting concoctions, which locally in South Africa are known as nyaope or unga, and an inappropriate and overprescription of illicit opioids pose public health and social problems in the country. Opioid substitution therapy is also known as opioid agonist therapy. In some literature, they say opioid agonist treatment, so we'll use the term interchangeably, but for the sake of this presentation, I'll stick to opioid agonist therapy. It is the standard guideline for treatment of opioid dependence, according to World Health Organization. Opioid agonist therapy is a combination of specific pharmacological and psychosocial interventions to reduce illicit opioid use and its related harm. I want to stress the point for an understanding that this OAT is not limited to pharmacological treatment, but is a comprehensive approach, including pharmacological as well as psychosocial interventions for people who use opioids. Methadone and buprenorphine are recommended medications for opioid agonist therapy. However, in general, methadone is recommended over buprenorphine because of its effectiveness and cost issues. Next slide, please. Currently, the use of methadone in the public sector is limited to short-term opioid withdrawal management at hospital level. The limitations with short-term use of methadone include, among others, the high rate of relapse and increased risk of mortality on return to use. Although OAT is being implemented in the private sector and through donor-funded private sector projects, the feasibility, acceptability, and effectiveness of providing opioid agonist therapy in South African public health facilities is not known. Following a motivation for expansion of methadone to include opioid agonist therapy for use at the primary healthcare level submitted to the National Essential Medicines List Committee for review, a recommendation was made that an implementation research project on OAT in selected public health facilities be conducted. I want us also to understand this, that we know that methadone is working well. We know that it can help people with substance user to recover. However, the challenge is the service delivery platform. That is why we say it is not well known in the primary health care facilities if it can be implemented. Next slide, please. In view of the medical and psychosocial expertise and resources that are required to implement opioid agonist therapy, community healthcare centers will be the better equipped primary healthcare facilities to render this service. It is therefore imperative to explore and understand the implementation of opioid agonist therapy in primary healthcare facilities with a focus on community health centers. What we need to understand here about the environment we are speaking about, especially primary health care centers, clinics versus community health centers, we need to note that this is a Schedule 6 medication. So we need to make sure that there is an environment whereby there is access to a prescribing doctor and also access to people who administer medication in line with the current legislation. So the findings from this implementation research will help to inform the rollout of opioid agonist treatment in the country in a safe, cost-effective, and efficient way. Next slide, please. The objectives of this project, it is to assess the feasibility of implementing opioid agonist treatment in a community health center setting, to develop the standard operating procedures for opioid agonist treatment, which are aligned to relevant World Health Organization guidelines, the NEMLEC mental health conditions, opioid dependency, non-EML protocol, and the OST checklist for provincial pharmaceutical and therapeutics committees suitable for use in a community health care center setting in South Africa. The objective also is to develop a training, orientation, and information material for different categories of staff in the selected facilities and stakeholders on opioid agonist treatment. To train all the staff, approximately at this moment, we are looking at possibility of training about 160 officials, that is about 80 officials per facility in implementing facilities, including but not limited to managerial staff, clinical staff, administration staff, general staff, and security staff. I want us to understand, especially before you move, the reason we want to train all officials is the fact that there are also some attitudes towards people who use drugs. So that is why it's important to train all officials, including security staff, so that people are not maybe blocked to enter and use our facility. Next slide, please. Objectives as we go through is to propose a patient flow suitable for clients on opioid agonist treatment who need to come to the facility on daily basis for their daily dose. And to observe the implementation of opioid agonist treatment in selected facilities against a set criteria and document the findings regarding the feasibility, acceptability, safety, and effectiveness of providing OAT in selected CHCs. Is also to make recommendations to address the identified gaps to build on the identified strengths to assess for safety and quality of opioid agonist treatment in community healthcare centers, including measures to prevent diversion for illegitimate purposes. One of the risk factors about methadone use may be a risk factor. That is why current scientific evidence suggests that it should be directly observed medication for the first few months, which means the clients have to go to the CHC facility on a daily basis. One of the other objectives is to strengthen intersectoral collaboration. Substance abuse cut across many organizations. So it is very much important that we collaborate with other intersectoral organizations. Next slide, please. So the project update. Technical support have been sought through a service provider to implement opioid agonist project in selected community health centers. The bid specification committee have been appointed and has concluded bid specification to appoint a service provider to assess the feasibility of implementation of OET in selected community health centers for a period. The project will be initially for about 20 months. As I speak now, bid documents have been published in the National Department of Health website on the 4th of July 2024. There will be a compulsory briefing session which is scheduled for 23 July 2024. And the bid closing date is the 8th of August 2024. It is anticipated that the project will be implemented in 2 community health centers, one in Mpumalanga province, that is eMalahleni local municipality, and one in Northwest province, that is Madibeng local municipality. We have not yet selected the specific CHC, but however, the project staff together with the colleagues in the province will help in identifying the CHC where we'll start this implementation. Next slide, please. The specific CHC will be selected in collaboration with the provinces, as I said, and it is anticipated that about 30 participants, 15 per side, will be recruited to participate in the study. The first initiation of methadone is expected to start somewhere in January 2025 and monitored for 12 months. The reason maybe you see this gap is this is going to be an evidence-based implementation research where we still have processes of going through ethics committee for ethical approval. So methadone will be initially procured through the National Department of Health procurement system. And for sustainability, as we continue, it will be sustained through provincial procurement system. Next slide, please. Progress report on implementation of opioid agonist implementation will be shared with NEMLEC to assist in reviewing the possible expansion of methadone to include OAT in standard treatment guidelines and essential medicine list. I think you have seen in the presentation that the processes which are to be undergone through when we update medication on standard treatment and guidelines and essential medicine list. So the similar process will be followed, will be strengthening evidence about methadone so that it can be expanded to include OAT. Findings from the implementation research will also help to inform the rollout of opioid agonist therapy in the country in a safe, cost-effective, and efficient way. Next slide, please. Thank you very much for your attention.
I'd like to just thank the presenters. Thank you very much for good presentations. I think we've only got a few minutes left. I wonder if we can see if we can answer a few of the questions. I think, Leslie, I don't know if you can see the question and answers, because I think most of them are coming to you. I think the first one we have talked about you have raised it about the Schedule 5. I think that this is an issue of that it has to do with the legislation that's important. Not really, there's not any change. It's just that we've been incorrectly doing it. So it might cause a practical problem.
Yeah. So I have been trying to furiously reply to some of the Q&A. So that one is because the Section 56(6) permits under the Nursing Act only allow prescribing up to Schedule 4, except I think for acute analgesia and midwifery units. What we would need to do is, there's two things. There has been an application made to SAHPRA actually for rescheduling of fluoxetine by a group of people, but we also would need to examine the Nursing Act and the need for specialist nurses and specialist registers. So there's an enormous gap in that these patients are at primary care facilities and there is nobody qualified to prescribe for them. And this probably should be raised quite vociferously with government. Shall I go through some of these Q&As? Is there time? And I'm sorry, we went through quite a lot.
Yeah, I think I think the next one is about regulation of herbal medicine for drug substance abuse.
Yeah, so I'm not sure how that's been regulated. I think it's, and I see the question was also related to pharmaceutical medicine. So that is in terms of pharmacy is easy. The safety and the quality is there. The scheduling system is to help prevent access to harmful medicines, which are dependency forming. But with herbal medicine, I think it's much more complex, and I can't really answer that question.
Okay, I don't know if you go through the list, choose some to answer, about whether nurses can, yeah.
Okay, there's a couple to the OST. Okay, there's one about haloperidol and Ativan IM will be phased out. Okay, for that olanzapine IM. Will it be wrong for one to use both for the management of aggression as it was? Okay, so no, we've kept haloperidol on the therapeutic interchange database. The only reason we didn't put either or in the algorithms is because they get very complex, the algorithm, and to try and get it across. So what we're hoping is that olanzapine IM is far simpler. Haloperidol, in the past, I think many of us used it with no promethazine, and it should be used with the promethazine. Just to note that the TREC trial actually stopped the arm of the trial with only haloperidol because of the adverse effects, the acute dystonic reactions, and they are much more reduced with promethazine. So if your facility would prefer, and you can purchase haloperidol using the Section 21 buyout, and you can get it, and that's your practice, by all means, you can continue to use it. But we are moving with olanzapine IM and hope that we've got regular, sustained supply and that the algorithm is actually simpler to use.
I think somebody asked whether it will be available at PHG, and I think it's envisaged that it will be available at PHG as well.
It will, and I think it's not in supply yet. So we're having a hiatus at the moment, but it's still where we haven't got haloperidol IM. The olanzapine IM is not on national tender yet, but it will be, and you can buy it out at your district or hospital level. The other medicine that we've got in the therapeutic interchange database is clothiapine, which is 40 milligrams per mil. And we did send a circular out, I think, in 2020 with that algorithm on. Okay. But it will be throughout the system. It'll be available. All right. There's a lot of questions for Kalabi on OST now.
There's also quite a few questions about this 72 hours observation, the forms, and
so.
who can sign it and what. But I don't have time to look at that.
All right, so the 72-hour observation, so the Form 4 should preferably be filled in by a family member or somebody who knows the family, but it can be filled in by a healthcare provider, and you justify by explaining all efforts to get hold of a family member. The Form 5s, the one Form 5 should be filled in by a medical practitioner who's qualified to do a physical examination, but the second Form 5 may be completed by any mental health care practitioner. So that includes a professional nurse, psychiatric nurse, social worker, psychologist. They can all fill in the second Form 5. And then the Form 7, I think, is the head of the health establishment. The discharge in the Form 3 would be by the person responsible for the discharge of that patient from the ward, and it can be filled by any medical practitioner. I think by any mental health practitioner, but I'm not sure. But definitely by any medical practitioner, so including medical officers, and complete a Form 3 for the discharge.
Thank you. I wonder if we can have some of the questions about the methadone.
Just go back and see all the questions. The first question was, what will be the role of pharmacists in the implementation of OST program? The role of the pharmacist is very much important. The pharmacist will be dispensing medication in line with the Pharmacy Act. I think it's very clear. How does the OST program link to harm reduction objectives? I want people to understand that this term harm reduction is very much complex and can be confusing at times because it's very broad. However, opioid substitution therapy reduces harm caused by substance use. Just to be clearer, that at times harm reduction, they even include justice system and the rights of people who use drugs. But to definitely understand is that methadone, OST, using methadone will reduce the harm caused by substances. The other question is in the point training is the process going to involve the public sector. The training will initially start in selected facilities in Mpumalanga and in Northwest Province. So all stakeholders attached initially will train staff at PHC facilities. However, will also involve all people who are directly involved with our patients in the specific CHC. So in a nutshell, we'll train staff which are attached and relevant to a specific CHCs. The other question is, besides managing drug addiction, how do we link the other clinical conditions that people who inject drugs may have? I'm not quite sure if I understand the question very well, but I mean, besides managing drug addiction, it says, how do we link other clinical conditions that people who inject drugs may have? I'm not quite sure, but what is important is to know that people who inject drugs are at risk of also developing communicable and non-communicable disease. So this is holistically included in the CHC setting. Remember, we also want to make sure that when we implement this opioid substitution therapy, it's not an isolated management, but we also have to move towards our policy direction of integrating our intervention with all other health systems. I'm just checking the other question. There was another question which I think it was not clear to others. Where will we start implementing opioid agonist research? We are going to initially start in Mpumalanga and Northwest Province, and the findings will guide us on how to expand to other areas. I think one of the questions, they stated that there is this in Limpopo and another province. I want to assure you and maybe to understand that although OST is implemented, it's not implemented in the public sector by us. There are some private sector organizations as well as donor-funded organizations which implement OST. However, the service delivery platform is not the same as the one which we are moving towards. I'm not quite sure we can help if I didn't cover any other question.
Thank you.
How are we to apply for the pilot study? I'm not quite sure if I understand this question very well. To apply, or maybe it says to apply for tender. If it's like that, you can check on NDOH website.
Yeah, I think the plan is to expand this, but we first need to go through a bit of a learning process to sort out the practicalities, because it needs quite a lot of support. I think that's why we're starting it just in 2 sites, is to learn from that. Leslie, I don't know if there's anything else that you would like to. I think we wanted to just finish it in an hour. Any other of the panelists still have something to say?
Just one question that I've seen that I was responding to now. So the deleted medicines, the midazolam, the promethazine, and actually even the haloperidol IM, they're not deleted completely from the EML. So midazolam and promethazine are still available for emergency medicine services, for other conditions. They're still on tender, and they may still be used. And haloperidol IM is still the first choice medicine for delirium, with olanzapine as a second choice if the haloperidol is not available. So these deletions are not absolute, they're not available anymore. The medicines are still there. Thanks.
Thank you very much. I'd like to thank everybody who attended today for this opportunity to interact with you, and all the presenters as well. And I hope, if there's any other unanswered questions, you can always reach out to the SAEDP, South African Essential Drugs Program, at the email address we just given, and we will try and answer in your questions. Thank you very much.
I was